Now I'm going to introduce the second speaker, Professor Justin Ezekowitz, the co-director of Canadian Vigor Center, the professor of Division of Cardiology, University of Alberta. It's director of the cardiovascular research, also University of Alberta. He's going to speak about sodium restriction. Dr. Justin, with us? Okay. Do you hear me?
I can, thank you.
Okay. Go ahead, please.
Well, Sabu al-Khair, thank you very much for having me and being part of your conference, and it's my great pleasure. And like Dr. Zeroth before me, I would like in the future for us to be in the same room so we can enjoy participating together. So I'm going to talk to you about something a little bit different, and certainly is I would say, a little off the beaten track for most people, and not something that they would normally focus in on in a usual practice. But it turns out we probably do this every day as we talk about salt in the diet with our patients with heart disease. By way of introduction, here are my disclosures, which are also available online if you are so inclined to have a look. I'm also not a dietitian, so I would just warn you that my knowledge of diet has been informed by this clinical trial, and therefore I don't have a lot of good other data on other diets of note. But here's what I'd like to talk about, what is the real issue about salt and salt in the diet. When we study salt or sodium in the diet and we recommend it to patients, we really have to think about where does this data come from. And so I would highlight that, first of all, we need to think about which population are we studying or what was studied, such as hypertension, coronary disease. Was this for prevention, or done in the elderly, or for kids for preventing future disease? A lot of the data from the PURE study is all in non-heart failure patients, as in it's not in the population I'm interested in, which is heart failure. We also have to think about what is the dietary context of this food, as in eating what, when, with whom, and how. And this is of particular importance as eating is generally a communal act. We sit down for meals together, we eat with friends, we sit down always together and often eat the same food. So we have to think about the context of that food. We have to think about what are we measuring in sodium? How do we measure salt in the diet? Is it simply counting what you ate and looking at a package label? Or is it a bit more complex than that? And finally, what outcome do we want to measure? Is it blood pressure that matters, or is it things like mortality that matter? So I'm going to walk through a couple of things, and I promise you it'll be probably something different you haven't thought about for a while. And the fundamental part is we've been talking about salt for so long, it has kind of it's like folklore. It is part of what we do, yet we don't always think about where it started. And it really started in the 1800s, where people started to recommend cutting back on salt for treating dropsy or renal disease. And so it had its bearing in the 1800s, but I'm going to skip to the 1970s to kind of skip over that section. Most people are aware of the DASH trial. The DASH diet was a low sodium diet, and it was also high in potassium. And this is where we base almost all of our recommendations from. So just it's worth thinking about this in why it's important. So in this trial, which was a smaller number, about 400 patients with hypertension, it started with 3,200 milligrams of sodium in dietary intake and reduced it to 2,400 and 1,600. And then the control diet versus the DASH diet. Every meal was made in what's called a metabolic kitchen. So the patient came in, got 3 meals a day, and it was for 12 weeks. So this is a highly controlled experiment, and it showed that the blood pressure reduced quite significantly, as did the urinary sodium. Well, that's really fascinating. However, that's a 12-week duration study from which we base almost all of our recommendations on. There have been other observational studies since this. But this is one of the few randomized trials out there testing this actual hypothesis. So when we get to heart failure, which is the other end of the spectrum from hypertension, how should we think about this? Well, first of all, heart failure is associated with a lot of neurohormonal activation and abnormalities in autonomic control, and that generally leads to sodium and water retention, and that's often why we use diuretics. So we've really focused in on dietary sodium for controlling the risk of volume overload, which is something we would see in clinical practice every day. But there's very little evidence that supports this practice. And we spend a lot of time and, of course, dollars doing this. But so is there any value in doing this? Should we abandon this policy of restricting sodium in the diet and go back to eating all the salty goodness that we like to enjoy at conferences? Perhaps. This is a terrific review done by Gupta et al. In Circulation in 2012, and it really lays out the issues around this topic very well. At the very top, you see that people would say, well, let's recommend a low sodium intake. And on the right-hand side of the screen, you can see that this is all green, generally means good, that maybe that would mean to a lower diuretic dose, reduced congestion, reduced myocardial stretch, as in kind of a compensation effect. And so maybe that would drop the wedge pressure. And that would lead to ultimately compensated heart failure. So, well, that's great. Well, let's think about what would also happen if we did something else different. What else could it do? Well, it could do all these things, such as with a contraction of intravascular volume, you might have more AVP release, aldosterone secretion, and more retention of renal sodium and water. It could be reduced renal perfusion, reduced cardiac output, reduced sodium delivery to the nephrons, and all these could ramp up renin secretion and angiotensin II. All of these things leading to elevated systemic pressures and transudation of fluid and decompensated heart failure. So we need to be pretty sure we're not tipping the balance in the wrong direction just by a simple recommendation that's really not being tested. So we've done a lot of observation on this topic. People have looked at large cohorts at this, and it's led us down a garden path. This is a picture, of course, from a Canadian lake in the Rocky Mountains. So I just throw this in there for a bit of change of scenery. So the clinical question that I've started with is, does advising a patient with heart failure to lower the amount of sodium in their diet change the clinical outcome? It's a very simple question that we'd all like to know the answer to. And there are a number of observational studies that I just want to highlight that have been well done. This one's from our colleagues in Ontario, Canada, and just in 123 patients with heart failure, looking at what happens if they are just eating a lower sodium or higher sodium diet. The lower sodium diet is in the red and the black, and the very high sodium diet is in the blue. And those patients eating a higher sodium diet were observed to have a higher rate of hospitalization and a higher mortality rate in an observational study with all the caveats around that. So that's really the limit of it. There are other studies that have since been published, but they really come down to that slide that I've just shown you. It doesn't get any better than that. The studies from the PURE and other observational studies are very much non-heart failure based, so I'm skipping over all that data. So what about randomized trials, and how would that inform us? So there are very few high-quality randomized trials that specifically tested sodium in the diet. There are trials that have tested sodium by giving it by IV, for example, and there's a whole series of trials that have been done that give a low sodium in the diet, accompanied with a very high dose of a diuretic. So I've not really covered those. They're mostly in-hospital-based studies or very poorly controlled studies. So here's one study which I think is just observationally interesting, published in 2018, small RCT in acute heart failure, this time with HFpEF. It's looking at 53 patients, 2 groups over 7 days, so very short duration. And it just shows that very tight restriction of sodium, this to only 800 milligrams of sodium, so very tight sodium control, and 800 mils of fluid, so very strict fluid control versus usual care, which was basically eating as many bags of chips as you could have and drink as much fluid as you could. But they didn't see any change in BNP, weight, or congestion. So those are 2 extremes. 800 milligrams of sodium is pretty tight, as is 800 mils. That's almost cruel and unusual punishment. So this showed that in the most, the one experience that should make a difference, it made no difference in some of the biomarkers and things we will follow. But of course, thirst went up in the restricted group, and that may have had a detrimental effect on how patients feel. Another small RCT done by my colleague, Eloisa Colon Ramirez, done in Mexico City, showed that in this group of just under 200 patients, as the outpatients treated in Mexico City in a heart failure clinic, that in the black line is the intervention, that is dietary recommendations of our sodium restriction to less than 2.4 or 2,400 milligrams per day provided by a dietitian. So they're seeing a dietitian in this context for that recommendation versus the usual care or control group. This is the usual recommendation somebody would give in practice, which at that time was not anything really much about sodium. And what they showed really was, even though it's non-significant, that and the scale is quite tight, it gives an inclination that even over as short as 12 months, there may be some difference in the outcomes of these patients following a stricter diet for sodium than the control group in a randomized trial. And this RCT is small, it's got modest power, but it does give us an inclination of the direction that we may want to travel. So what have our guidelines recommended based on all this very low quality data? Well, first of all, most of the societies, such as AHA, ACC, you hear Dr. Zeroth mention those, and the ESC have moved away from a sodium restriction recommendation. And even our own Canadian Cardiovascular Society, we've been starting to move away from it for years, and this latest update will probably move us even further away. But the Institute of Medicine has still kept a recommendation of less than 1.5 or 1,500 milligrams of sodium per day for all people. That's basically all of us who don't have heart failure. So the guidelines have spoken and said, well, the evidence isn't great, so we need to not make a recommendation if the quality of evidence is poor. But here's how our patients feel. They feel like the heart function clinic dietitian is really waiting to pounce. And so the dietitians are very effective and very good at what they do. And this is the way our patients sometimes feel, that they are the victims of a very good hunter, which is our dietitians, and they're excellent at what they do. So how do we measure sodium? And then I'll come back to some other things about how do we think about this. So in practice, we have to think about how do we measure our own sodium or adherence to any therapy? Well, there's a number of different ways. We're very used to blood, so plasma. Well, that's very easy to do. It's tightly regulated physiologically. The labs are good. However, it reflects only an acute change. It is not related to sodium intake in the diet. So it's completely unrelated to sodium in the diet on the strictest sense, with some exceptions about things like SI-ADH, which is a different type of disease state. We can measure in urine. That's apple juice in that glass, by the way, just for your information. It's easy to do with a spot urine and harder to do with 24-hour urines. It takes a very complex ask of the patient to do. It's variable based on the methods. There's a lot of debate on whether or not the formulas that are used to calculate it to extend it from a spot to a 24 are actually valid. And it's really rather rationale is that 90 to 95% of the sodium we eat is excreted directly in the urine. So that is an assumption that is maybe holds true, and I'll show you in the next couple slides what we can do. And then finally, we can ask people to count what they're eating. And that rather atrocious looking burger there is probably not what we should be eating. It's measuring diet is actually easy to sometimes do. There's variability in reporting. People have to be honest. You need to know the food and the exact makeup of the food, which is difficult. But there are actually some really good techniques about food consumption that have been validated through a variety of different techniques. And it does reflect consumption, not excretion. So how does it perform in the clinical practice world? Well, this is a nice little study also for my colleagues in Toronto, where what they did was they measured the urinary sodium excretion as well as the estimated food sodium intake by dietary surveys. And the first in the top left are patients who are seen in a cardiac clinic but do not have heart failure. And the top right is patients with heart failure but not on a loop diuretic, such as furosemide. And then on the bottom is patients with heart failure and also on a loop diuretic. What you notice is that there's tight correlation for people who are not on a diuretic, but once the loop diuretic is put on board, there's almost no correlation with spot urinary sodium. So that really eliminates the chance of using urinary sodium as our measure, because most of our patients are indeed on a diuretic. And so that will also be further influenced by multiple diuretics or dose. So we have to be very careful about not measuring urinary sodium as our measure. So when we start to look at that food versus urine question, we start to realize that the excretion does matter. And if we finally put this together, here it is. For patients not on a loop diuretic, it's pretty well correlated, so that's great. You look at this Bland-Altman plot and say, we can measure a urine sodium intake and get an approximation of what they're eating. But if they're on a loop diuretic, let's not bother. And so this has been well looked at, and I think we're pretty comfortable now that we just have to measure intake rather than output. So what is the intake? Many people, if you try to estimate what you've eaten and you're asked to collect this and you ask patients to collect it, it's about food recall, which is generally an underestimate, and it's generally about a quarter underestimate, so a 25% underestimate of the food that they've eaten and also the contents. Food records are pretty good, but after about 3 days of a food record, you don't gain much by going for 2 weeks. And it's an actual record, not a recall, which is better. And then there's programs which are highly sophisticated, and they take whatever food was eaten, and they processed that into and spit out all its nutrient contents with very high fidelity. And these have been well validated in the nutritional literature, which was a real education process for me to understand it a bit better. But it is quite incredible what it can process based on the information provided. And here's two examples of what our patients may see. And both of these are labels directly from Canada, so they're relevant for the rest of the world as well, because we all have labels of some sort. And this is just looking at tomatoes. We all like tomatoes for making many dishes, but I've highlighted the sodium of 400 milligrams in this can of tomatoes. This is Canadian, so it may be higher than in Egypt. But I see on the low sodium on the right-hand side, there's only 15 milligrams of sodium. You say, well, this is fantastic. We can cut our sodium just by limiting canned tomatoes. Well, that's true, but look at the amount of potassium they use now to supplement the low sodium flavors. They need to get a potassium salt in there. And in fact, there's 260 milligrams of potassium salt in there. Now, why does that matter? Well, if patients are on ACE inhibitors or MRAs, and we're worried about their renal function, the higher potassium diet may be problematic. So we have to be very careful of whatever move we make. And so here's a real example of a food record captured by our patients, a patient with heart failure, and they write down everything they've eaten with the brand names, and then that gets cranked through into a core lab, just like we would do a core lab echo, a core lab biomarker, and then it spits out a whole bunch of variables. So the clinical question that I've asked is kind of really reflected in this slide is, we've got the question, now how do we tackle this? Well, we did a pilot study called the Sodium HF pilot study, published in American Heart Journal, and it really showed that the diet was feasible if we wanted to lower sodium in the diet and people were adherent. And for people that were adherent to it, it looks like there might be an indication that even natriuretic peptides drop with that, but really too underpowered and just a provocative question about feasibility. So we published our design paper, the bigger trial, which I'm about to show you. So very much surprisingly, we were able to get some grant funding to do a large clinical trial called the Sodium HF trial. And it's called, I had to come up with an abbreviation. I spent half a year just coming up with the abbreviation, Studies of Dietary Intervention Under 100 Millimoles in Heart Failure. And you can see this is funded by our federal government agency and a hospital foundation. And we have a Twitter account, of course, if you'd like more information. There's also a website. And what we wanted to figure out was, does a lower sodium diet change the clinical outcome that we are all very much worried about for our patients, which is all-cause mortality, cardiovascular hospitalizations, and cardiovascular emergency department visits? And in the secondary objectives, look at quality of life, exercise capacity, NYHA class, and other outcomes beyond the 12-month interval. And so we've just finished enrollment, so I'm happy to report we've just completed enrollment, and it's 25 sites across these 6 countries, which are in North America, South America, and Australia and New Zealand. It's a randomized trial. It's an open label because people like ourselves are free feeding, and we have to do our shopping and eating as we do. And it's got a blinded adjudicated endpoint. We include people with HFpEF and HFrEF, and eating at least 1,500 milligrams of dietary sodium, which is basically pretty common in North America and everywhere we've studied it. We randomize patients into the 2 groups, which is 65 millimoles or 1,500 milligrams a day. So just try eating that yourself. It actually takes a bit of effort, versus usual care. And usual care, which we're tracking quite carefully, is around 2,400 milligrams a day in most situations, and even in a heart function clinic, and even under the advice of a dietitian. So as good as we think we're doing, we're actually still sticking to around 2,300 to 2,400 milligrams, even in regular clinical practice. Our intervention is pretty simple, is we've created menus that reflect the same energy input, so people are not eating fewer calories, but they are just eating lower sodium. So we have to come up with some crafty ways. And one of the ways is to give patients sample menus rather than say, go eat less sodium. Well, that's pretty hard for me to follow, let alone a patient who is already struggling with other issues. So we've got some recommendations and interventions. The dietitians counsel them, and the menus are meant to just change the sodium without changing other factors. So here's a look at the rest of the world. Unfortunately, just due to funding, I couldn't include my European colleagues or Middle Eastern colleagues, and that's always does give me some pause that I do wonder what the outcomes would be if we had the Horn of Africa or the Middle East or Europe involved, as they may be different dietary eating patterns and different issues at hand. So I want to make sure we finish on time today, and I just want to cover off that we are doing the sodium HF trial. In about this time next year, we'll have the outcome results, and I look forward to being able to present at a future time, hopefully in person, and have a lot of discussion around this very complex topic that I think we end up talking a lot to about our patients, but really don't have a lot of the data to support maybe our clinical recommendations that we would provide any patient. So my advice to generally in this area, and what I'm following, is we need to test unproven dogma in anything we do. If it's fluid restriction or sodium restriction or the ordering of therapies, think about the patient, the intervention, and the control. We don't need any more observations, so intervention is the way to really look at it. And so the sodium HF, and there are some smaller RCTs that have been started around this topic. This picture is taken from the Rockies and the Icefields Parkway, which is the Athabasca River. I advise you all to, as soon as you can, and as soon as we're allowed, to revisit Canada, much like I would like to visit you in Cairo. So thank you very much for your attention.
Okay. Thank you very, very much for this new topic. I know it's an old topic, but nowadays I think a new topic called the sodium heart failure. In hypertension, this is called salt sensitive and not salt sensitive. In hypertension, not in heart failure. The first question, it is the same in heart failure? And also, it is depending on what drugs you are using. I mean, if you're taking ARNI, for example, and diuretics, you have to adjust your sodium amount according to the drugs, or it doesn't relate to it? It's a separate entity for treatment.
Yeah, that's a very astute question. Is wondering the two parts to that question. I'll take the second part of that first, which is if somebody is on an ARNI or an ACE or other therapies that may modify the behavior of sodium intake in the diet, as in they can eat the same sodium and get a different response if they're on an MRA or an ARNI. But we don't actually know the answer to that question. And I think that's one thing where what we've been very diligent about collecting in the trial that we're looking at is collecting that data so we can, secondarily be able to help answer that question. We have a number of patients who are on an ARNI, and the majority of our patients are on an MRA. So we'll have a nice split about looking at the answer question within the context of a clinical trial, as there is not a lot of good other data that tests that theory. To your first point about salt sensitivity, this remains to be a very good question. And the majority of the data that we look about salt sensitivity and hypertension comes from the 1960s and 1970s. And it doesn't necessarily hold as true as we think when we start to think about different populations. We know a lot more about the genotypes of individuals with presumed salt sensitivity, whether or not that's related to renin-angiotensin pathways or other factors such as renal processing isn't quite as understood as I think we thought it was. So in heart failure, I think it's probably less of an issue, mostly because the end stage of any disease is probably it's damped down a lot of those effects. So I think there's a lot more uncertainty in the salt sensitivity world than we would like there to be.
Okay, Ammar.
Thank you, Dr. Justin, for addressing this very important and practical topic. Although it is a routine advice for patients with heart failure to reduce salt, that we don't have an evidence or a hard evidence for this is valuable or not, and the outcome from trials are mixed. Some small trials show that it's beneficial, others show that it may be harmful. We are speaking about sodium restriction, which represents 40% of salt. About 40% of table salt is sodium. Do you think there are possible difference in patient response depending whether it is an acute or chronic heart failure? That's number one. Number two, is there certain phenotypes of patients with heart failure that may have benefit from salt restriction? And it's a matter of ejection fraction or a volume overload that it's more important for salt restriction. Thank you very much.
Thank you for those great questions. So let me start by addressing the last one, which is about ejection fraction. I actually don't think it's going to matter one bit about ejection fraction, as that's such a poor marker for the severity of disease, for a lot of other factors. It may have impact for our clinical therapies that are tested and how they're tested, but I don't think it's going to have the same impact, as many of the same mechanisms are at play in HFrEF, MREF, and HFpEF, so across the spectrum of EF. I hope one day we will no longer be speaking about EF and more about things that make a bit of a better difference around that. With respect to the acute versus chronic issue, I'm a little careful about that because I think we certainly think that there's probably a role to play in acute hemodynamics if you salt load people. So some of the first experiments were to give college students 20 liters of normal saline to see what happened, like as an IV. But in the acute world, where a patient may show up to an ER with 5 or 8 pounds of extra fluid, and some of that's going to be salt driven, I'm not certain it makes as much of a difference. And in fact, I think every single time I see this in clinical practice on the wards, I think, is this really making a difference that we're limiting salt in the acute world versus the chronic world? What I think we're trying to do is much like the chronic effects of things such as ACE inhibitors or SGLT2s, is we're trying to modify the underlying disease. And so I think if we're going to recommend it in the chronic world, we should really know that it has an impact on the chronic disease. And the acute disease would be another trial I'd like to do, and maybe that's one I can do in Egypt, but we're not there yet. So I think the jury is still out about it being acute versus chronic. My sense is that it's probably less important than we think about in the acute world.
Dr. Hamad Gamal.
Thank you very much for your fantastic talk. My question is, do you recommend the routine and regular measurement of sodium in patients with hypertension and heart failure?
Right, and so generally speaking, what we now practice in our heart function clinic is we have them seen by a dietitian, and we do a general food recall just based on resources. We can't measure sodium in the diet for everybody. Within the trial we are, but we don't measure blood sodium as a measure of anything. But what I've started to do in the acute world, as in when I'm seeing a patient with trying to diurese them, I've started measuring urinary spot sodium. But that's more about the efficacy of my diuresis that we're trying to achieve. And there are some nice nomograms around that, but that's not so much about dietary sodium. I hope I'm capturing your question correctly. I apologize if I've not answered it the way what you were asking.
Dr. Mahmoud Hassani.
Thank you for your great presentation. My question is about impaired kidney function usually coexists with heart failure. Don't you think that the presence of impaired kidney function would be a stronger motive for sodium restriction in patients with heart failure?
Yeah, that's actually a terrific question, as I think if we kind of go to the extreme of that, which is the hemodialysis world, that's actually kind of almost a model for that. Short of hemodialysis, we're really uncertain about that effect. My sense is that the more impaired the renal function is, such as when we get into the eGFRs, certainly below 30, I think there's probably a greater effect. If there is going to be an effect, it's going to be in that population. And so the patients with much more preserved renal function, it's going to be very difficult to see that that's going to have any impact. And so within the clinical trial, we are capturing eGFR and renal function. And I think that's, we've highlighted that as one specific subgroup we want to look at to see the potency of the effect across eGFR. I would sense that if it's going to have any effect, the lower eGFR is where it's going to be at. And so we have to do this big trial to understand the overall effects, and then we'll be able to break it down into the more finer cuts of that. The dialysis world, they've not done a great job of doing clinical trials in this area, so they just blanketly recommend cutting sodium back, which unfortunately impacts the overall diet quality, and I think is probably a detrimental effect for people on dialysis.
Okay, thank you very much, Professor. As we know from clinical practice that salt restriction, diuretics helps a lot patient with heart failure and edema. How can you explain that had been removed from the recommendation from the American and European recommendation to restrict salt restriction? It's a little bit nonsense.
Yes.
Yeah, so I think this was a bit of, I think this was a good move by the guidelines to remove salt restriction from the guidelines, as there was a lot of carryover effects of historical practices in guidelines. So there's many recommendations that were made based on clinical practice. And people said, well, just keep recommending that. And they kind of punted them, they kept pushing them forward. But I think many of the guidelines have started to apply much stricter criteria for evidence and say, okay, well, if a new drug or new device or new therapy of any type comes along, we need to apply strict evidence, and we need to start applying that to all of our therapies, whether or not it's exercise recommendations, recommendations about vaccination, recommendations about a defibrillator. And so they've moved away from making recommendations in areas where there is uncertainty, or making a recommendation that says, well, here's our best guess is the area, but then advising people that this is an uncertain recommendation. So many of for example, the ESC has said, we will only give it a tier 1 or class 1 recommendation if it meets the RCT criteria. Well, clearly sodium does not have that. And so you start to kind of ratchet that down about the level of evidence. And that was the rationale behind it. I think it probably caused some consternation with people because it's a change in practice. But I think it was a smart move.
Dr. Gamira?
Thank you, sir. It was a very interesting presentation. I'm asking about, there was a matter of debate, how low should be too low to decrease the sodium, because there was just a recommendation, I think, about the World Heart Federation, which says that it should be moderate decrease in the salt for heart failure patients, especially in the elderly. So how low should we go too low for salt restriction?
Yeah, so certainly that's been an open question, much like it is for things like cholesterol and other factors. How low is too low? I don't know that we know the answer to the question, and I think I draw upon a couple of different experiences in humans. One is in babies. Babies each have barely any sodium in their diet based on what based on a mother's breast milk and other formulas. So there's almost no sodium in the diet, and they tend to do just fine and grow quite healthy and have very healthy hearts and vasculature. The other one is from groups that have been really isolated and need a low sodium diet based on hunter-gatherer societies. And they also do extremely well, and they're eating as low as 200 or 300 milligrams of sodium a day, like basically nothing. That's one caper. They're really their olive consumptions would tip them over the top. And so I don't think there's going to be a low point in terms of sodium, but what it comes back to is the quality of the overall diet is probably far more important than the actual level of the sodium. Such as are they getting high quality other nutritional elements in their diet and enough nutrition, calories, protein, etc. And so we'll be able to measure that by some of the data we have, but we won't be able to test that it'll be associative rather than the randomized part of our trial.
Okay, last question, Dr. Atif Bahi.
Thank you, Justin, for your answers. When we speak about salt, it's a sodium chloride. And you know that when chloride is decreased, this is independently and incrementally increasing the risk of mortality in patients of heart failure. What's your explanation for what I say?
Yeah, it's a great point. We just surveyed the literature recently looking at this exact question about serum chloride and its relationship to, for example, diet. It's, you're right. So low chloride is very tightly coupled to outcomes, hospitalization and death in patients with heart failure. No question, you're absolutely right. Whether or not that's coupled to the dietary intake is very loose. And in fact, it's probably not, unless people eat something that is weirdly coupled with chloride. It's actually not regulated in the same way, and it's more regulated much like sodium in the blood is regulated. And so I think you're right in the statement that low chloride is bad and as a prognostic marker, but as relationship to diet is probably pretty loose overall.
Okay, thank you very, very much, Justin, for this wonderful topic. As I said, it is an old topic, but nowadays it's a very recent topic. Thank you very much.